I want to talk a little bit in depth about how the biomechanics or the movement of these joints and these bones actually facilitate not only breath, but also facilitate proper movement and posture and organization of all of our movement in our body as it pertains to the pelvis, as it pertains to the arms and the spine. Let's start off with the relationship between the costovertebral joint, so where the rib actually articulates with the vertebrae. If you think of the head of the rib actually comes into the space between two segments of vertebra. So you have the superior vertebra and the inferior vertebra, and the disc in between. And the head of that rib is going to come in, and it has a little facet that articulates with the vertebra above. It has a fibrous connection to the disc and a connection or facet with the vertebra below. So if you think about the head of that rib, one of the things we think of is that it's going to move when the spine moves. So if the spine moves in extension, the rib's going to move forward. If the spine moves in flexion, the rib moves back. It's directly related to the movement of the spine. The second connection is the costotransverse joint. This is where the neck of the rib comes around and articulates with the transverse process of the vertebra below. And that also has impact on the movement of the rib. So when I go into extension in my spine, the ribs are going to open up like an accordion because the ribs are going to move forward and open up to be able to increase, right, or actually decrease the pressure inside the lungs and facilitate inhalation. As the vertebra move into flexion, the ribs come together in the front like an accordion closing in the front and causes exhalation. So that relationship to those two vertebrae is very, very important as it pertains to breath and as it pertains to movement. The way this works is that in the superior 1 through 7 vertebra of the thoracic spine, the articulation between the rib and the transverse process has more rotatory properties, more rotation, which means that the true ribs that come into the sternum, right, when they move into extension in the thoracic spine, it's going to cause an anterior movement of the chest. And the chest or the sternum is actually going to lift up as the upper thoracic goes into extension. And the ribs are rotating inside that transverse process. Okay? So it has a bias towards rotation. On the inferior ribs, or 8, 9, 10, the actual articulation with the transverse process is more planar. And we often refer to that movement as a glide. And because of that orientation, the bias is going to be more of a lateral translation or glide. We often refer to this as lateral breath or lateral movement of the rib cage. So the lateral lower part of the rib cage expands to the side, and the upper ribs are going to be more rotation, expanding anteriorly and posteriorly. Understanding the movement of these ribs in relationship to the vertebra is the idea of the different planes or diameters of movement of the thorax. The first one is the vertical diameter. And the vertical diameter movement consists of the diaphragm contracting inferiorly, increasing the space inside the thorax wall, which creates a vacuum for inhalation. It also could be the contraction of the accessory muscles that are going to pull the ribs up and increase the vacuum inside the lungs. The transverse diameter, or the second diameter of movement, is going to be one that we refer to as the bucket handle. That's going to be that lower one where we get displacement out laterally of the ribs, particularly in 8, 9, 10, and even 11. In the thoracic spine and the lower ribs, it's going to increase the diameter, which will create an inhalation. And the last one is the anterior-posterior diameter, which is what we spoke about with the superior ribs, 1 through 6, 1 through 7, that are going to have more of a rotatory and an anterior-posterior displacement of the thorax. Now, some people ask me, which of these is correct? And the right answer is all of them. And they'll say, which one is more important? And I'll say, all of them. Because the idea is that in complex movement, spontaneous breath is required. Spontaneous breath means that I should be able to displace my lung tissue in any orientation of gravity and any orientation of movement. So in Pilates, our goal is to create suppleness in the thorax so that breath can occur, or exchange of size of that thorax in any of those diameters to facilitate breath spontaneously, harmoniously, and efficiently in the body. So somebody who comes with a very rigid thoracic spine and very poor rib mobility is going to be purely dependent upon the diaphragm and the accessory muscles to exchange air. Well, you can imagine what would happen if your thorax was really stiff. As a matter of fact, I'm a big proponent to think that many of the orthopedic pathologies that we see today in our shoulders, our neck, and our lumbar are a result of poor mobility in our thorax. And that's why in Pilates it's so important to us to be able to restore mobility options in all planes, which not only facilitates spontaneous breath, but it also facilitates spontaneous movement of the rest of our body without excessive stress through shoulders, neck, and low back, which is where most of our mechanical and orthopedic injuries occur. The next part of biomechanics is looking at force couples, and this is really important to understand. Remember how I talked a little bit about spontaneous movement or complex movements? A lot of times in research, we're not allowed really to look at complex movements with things like needle EMG because we can't get approval of it. And so our research designs are often very basic. And so I want to talk a little bit about this connection between the rib cage and the pelvis and the role that breathing plays in maintaining the appropriate amount of stiffness for the anticipated load of movement. And we refer to this as the hydraulic amplifier. Now, this schematic of the hydraulic amplifier represents the diaphragm from above, which we've already discussed, the pelvic floor from below, which we've already discussed, the abdominal muscles all the way around the spine, which we've discussed, as well as the low back muscles, the quadratus and the psoas. And then also the deep low back muscles, which we haven't discussed yet, which are the multifidi and the rotators. Now, all of this is like a tube around an area that's enclosed. And the term that I want to introduce now is the intra-abdominal pressure. We often refer to this as the IAP. The intra-abdominal pressure would be if I could put a pressure gauge inside of your abdomen, and we can change, based on the activity we're going to do, the amount of pressure around the spine to protect and create that connectedness between the thorax and the pelvis and the stiffness around the spine based on the activities that we choose to participate in. An activity as simple as opening a door might not require a whole lot of intra-abdominal pressure. But if I was to lift a 200-pound weight, it would require a tremendous amount of intra-abdominal pressure to be safe. And this dynamic organization is something that happens spontaneously and subconsciously in a healthy person. So how does this work? If you could think that the activity that you wanted to participate in required a certain amount of tone or stiffness around the spine to be safe, it would recruit a certain amount of the multifidi and the abdominal muscles and the pelvic floor to be able to create that intra-abdominal pressure that's just right, okay? And if I'm doing that activity and then I need to breathe, the diaphragm is going to descend as an active contraction. So you can imagine what that's going to do to the intra-abdominal pressure. It's going to drive the pressure up. It's going to increase the pressure. So if you think of breathing in to a tightly held abdominal wall and pelvic floor, you can feel the pressure increase in your abdomen. If my goal was to keep the intra-abdominal pressure constant while I was inhaling, I would have to have an eccentric contraction of my abdominal and back muscles as well as my pelvic floor muscles to keep the intra-abdominal pressure constant. Then, when I exhaled or relaxed the diaphragm, I would need to do a concentric contraction, just enough, of the pelvic floor and the abdominal and back muscles to keep the intra-abdominal pressure constant. We refer to that as the hydraulic amplifier. Now you might ask, how does that apply? How is that important to me as a Pilates teacher? Well, the purpose of that type of co-contraction and organization is when we do sustained postures with dynamic breath. Functionally, that might be something like moving a box of books across the house. the box of books weighs a constant weight, and the body needs to have a constant stiffness to be able to hold that box. But between one room and the other room, you're probably going to take 3 or 4 breaths. And that change in breath pressure is automatically going to change the amount of organization of the muscles to keep that intra-abdominal pressure constant. Again, that's a natural and normal thing for healthy humans, right? So what happens when somebody is injured or has poor posture or poor organization of their body? Well, what happens then is that the body has to organize a different way to be able to sustain that intra-abdominal pressure, and often fails and makes us vulnerable to more injuries or poor performance. In Pilates, we teach this all the time. Subconsciously, we teach our clients and our patients how to use their body and their breath in a very dynamic way to be able to maintain that intra-abdominal pressure constant, or at least appropriate for the load that's being placed. Now, the more dynamic the movement, like dancing or moving across or running or golfing, that pressure has to change. It doesn't stay constant. And this is a very important point that we bring up here, that in Polestar, very seldom will you hear us ever use the word like hold or contract this muscle, right? Because in dynamic movement, a hold is going to interfere with the body's normal way of moving. And this leads us to the next topic, which is motor control. Another force couple that's really important in breathing is the force couple between the serratus posterior, superior, and inferior. We talked a little bit about this relationship of the ribs with the intercostal muscles, the exterior and interior muscles, and how they oppose each other, and the abdominal muscles. But posteriorly, we often don't think about breathing. And these muscles become incredibly important. And what often happens with new Pilates movers and teachers is they'll get a cramp in their lower back just behind their ribs. And they'll get this spasm, and they'll wonder what it is. It's probably the first time that you've done a forced exhalation fully, and that serratus inferior, that posterior inferior, is going into a contraction, and you're just not used to it, and you get that little stitch in your side. As we practice this idea of breathing and expanding our ribs posteriorly, and that force couple of the muscles above and below, we're going to have a much more dynamic displacement that we talked about of the anterior posterior and the superior inferior diameters of the thorax.